But yeah, so it's lovely to see you all here. Welcome to the Egenis seminar, and this is a special seminar in our calendar because it's our first joint seminar with the Welcome Centre for Culture, Environments and Health. So we're really pleased to have colleagues be welcome here too, and especially pleased, of course, to have President Dolezal to speak to us, who's a perfect speaker for kicking off this these joint events. Someone who's known to many of us from Egenis, of course, from the Welcome Centre too. So many of you may well know Luna's work very well, and better than I, but Luna works in all sorts of different areas, like phenomenology, philosophy of embodiment, philosophy of medicine. For many of us, you will perhaps particularly have heard of Luna's work in the Shame in Medicine project, and let's say a spin-off project from about COVID-19, Shame Sigma, and was that the event in the church, in St Pancras Church in town? That was from the Shame Medicine project. So it was a wonderful event in the lovely church, St Pancras Church, that's by the shopping centre. So the one that looks as if it's been surrounded by brutalist architecture on all sides. That was just a lovely event open to the public as well. So we're just really delighted to have Luna here. Just to let you know, in case this is the first seminar you've been to this year, the format is we'll have a talk from Luna, then we'll have a short break of 3 or 4 minutes or so that you can nip to the loo. Yes, I said 5 minutes last time. You give them an inch and they take them 1. So I have to be very strict now. If I say 3 minutes, you know I mean it. If I say 5, it's so that's for a quick comfort break, and then part of the reason for doing that is when we start, we'll have a slot at the beginning of 5 to 10 minutes or so, especially for early career researchers, so MA students, PhD students, and postdocs. So there'll be a bit of a break to think about your questions, and then we'll kick off. And the last thing I need to say is after the seminar today, we've got our welcome drinks to kick off the new year here at Egenis. So if you can stay around for a glass of wine or so, then please do, and we'll just be in the foyer out here. Oh, okay.
Yeah, thank you. I think I've got about 40 minutes of talk, but we'll see. I'll keep an eye on that clock. So it's nice to see everyone, and thank you so much for inviting me. It's really nice to be here. I feel a bit self-conscious because I gave a version of this talk at a workshop that Giovanna organised in May, and I don't know, were you guys there? Yeah, I enhanced it, so it will be slightly different. It was great the first time, so. There might be a couple of philosophers who were participating in this Chinese University of Hong Kong philosophy workshop who've seen a version of this talk. But what I'm going to speak about is a kind of sort of subfield of research for me. Like, as some of you might know, most of my research is in the area of phenomenology of self-conscious emotions, and I've done a lot of applied phenomenology in the realm of healthcare. This is related to that. I've been working with some colleagues at the University of York, and I'll talk a bit more about that, to do a piece of research around this robot, which is called Välkky. It's a Telepresence robot that's operated by nurse clinicians in a hospital in Helsinki. So it was a trial of this robot in Laakso Hospital in Helsinki. And we kind of came in to collaborate with this robotics company called TouchLab to do a kind of qualitative and ethnographic study around the robot. So it was a kind of case of a phenomenologist, which is me, philosopher, phenomenologist, working with some like super hardcore STS scholars from York to do this little piece of research, and some publications have come out of that. And what I'm presenting is a publication that I largely wrote in collaboration with my colleagues, looking at the kind of phenomenology of telepresence in the experience of the nurse clinicians. So this research, just to plug one of the projects that I work under, is kind of under the umbrella of this bigger project called Imagining Technologies for Disability Futures, which is funded by the Wellcome Trust. And the PI is Stuart Murray, a literary scholar at Leeds. And I'm a co-I on this project. So we've been doing like lots of different strands of research looking at technology and care and disability and healthcare. So the work kind of falls under the umbrella. The specific project was separately funded, and I've been working with Välkky, who is the CEO of TouchLab, the robotics company in Edinburgh, And then some STS scholars and medical sociologists, you may have heard of some of them, Nick Brown, Carl Atkin, Sarah Nettleton, and we had a postdoc called Daniel Robbins working with us. And this is funded by an ESRC, PSRC kind of IAA grant, this little project that we did. So we were doing qualitative research about the trial of this robot in Välkky Hospital. And my kind of role in that was to consider the kind of experiential dimension. So we're talking about nurses operating really complex technology, kind of nested technologies, if you think about, and I'll talk about it in more detail. So it was thinking about experiences of like motor intentionality, skill acquisition, sociality through a robot, and so on. Yeah, so there was quite a bit of press around this robot because TouchLab is a robotics company. Actually, they're not really a robotics company, they call themselves a deep tech company, and what they specialize in is e-skin, so it's skin for robots. So it's robot skin, so what that means is if the robot has its skin on, the person operating the robot wears wear a Tesla suit or wears haptic gloves that feed back haptic sensation. So if the robot touches a table, the person operating the robot will feel the table. So this is a kind of next level of telepresence, which is usually just audio-visual feedback. So what they were doing was putting skin on this robot, and their vision, which did not play out in reality, was that the robot would have skin all over its arms and on its torso, and the operator would wear a Tesla suit, and so that they could get this kind of haptic feedback across like large areas of the body. And yeah, this thing of like a robot designed for space, you see a lot of like Elon Musk-esque like tech bro kind of imaginaries at play in this stuff. Another bit of press around this. And the reason there was quite a bit of press is this was a kind of world first trial. So robots are often trialed in, as I'll talk about in a bit, are not trialed like in the wild. They're often trialed in staged artificial environments that kind of emulate the wild. So this was like quite exceptional. I don't know how they got ethics for it, but they let this thing loose in like a real hospital ward with stroke patients. So we're never about ethics in the UK. But somehow I think there's like a kind of like tech optimism in Helsinki or Finland rather, that they're really keen to be on the cutting edge of this kind of technological development. So what I'm doing now is I'm going to show a 2.5 minute video clip, and it's a promotional video that was made by TouchLab about the robot and this project. And it'll just give you a kind of better sense of what exactly we were researching. So I've been told this is easy. I go here and we'll press play. And hopefully this is
Välkky is a sort of a general purpose teleoperated humanoid robot, which basically means it's controlled by a nurse or a clinician in this case. Välkky is operated using a haptic teleoperation setup. So you wear virtual reality glasses, you have a virtual reality controller and a haptic glove. You can control all the fingers individually, and you can feel touch from the fingertips and the palm, as well as potentially the rest of the body through a Tesla suit. This touch enables Välkky to be a safer robot than was possible before, and that's why we can carry out pilots in an actual real hospital ward for months, because we don't risk patient injuries in the same way as robots without skin.
Laakson sairaalassa tällä hetkellä meillä on kävelyrobotti, joka auttaa erityisesti meidän AVH-potilaita kuntoutuksessa. Ja sitten meillä on ollut Välkky-robotti nyt pilottikäytössä ja sitten me suunnitellaan Laakson uutta sairaalaa tänne, niin siellä logistiikkarobotiikkaa on ollut kovasti puheissa ja sitten palvelurobotiikkaa myös.
Laakson sairaalassa Välkky-robottia käytettiin potilaiden kanssa vuorovaikutukseen. Kävimme potilashuoneissa, tervehdimme potilaita, saatoimme ojentaa pieniä asioita, kuten vesilasia tai kirjoja pöydältä. Tarkoituksena oli siis katsoa, miten potilaat suhtautuu robottiin ja millainen vastaanotto heillä olisi. Sairaalaympäristössä hoivarobotiikan tulevaisuus tulisi luultavasti olemaan hoitajan työparina. He voisivat auttaa raskaissa nostoissa, säästää hieman hoitajien selkää, olla silmäparina osastolla, tarvittaessa vaikka käydä infektiohuoneissa tarkistamassa potilaiden vointia ilman, että riskeeraa hoitajan tarttumaan riskin.
All right, so you can kind of see the robot in the wild. I'm gonna go for that one. Yeah, okay, cool. Yeah, so Laxo Hospital is one of the hospitals in Helsinki, and it's quite an old hospital, but they have a kind of multi-billion euro upgrade happening at the moment. So what they're doing is trialing a lot of new technologies, novel technologies. So when they actually design and build the new robot, there'll be space to accommodate them. So if you're going to actually have a robot like that in a hospital, you need somewhere to put it. So you need somewhere to put the VR chair and all of that stuff, so that they're kind of planning ahead. So that, I think that was partly in the mix about why this trial happened. So this is a report that was created by ROSE, which is a big interdisciplinary project that looks at robots and the future of welfare services in Finland. So there's a huge emphasis on this. And I really liked this because after watching that video, and actually it doesn't show Välkky doing all that much, it's a kind of waving and handing a book. It's not really doing anything. And when I first got involved with Zaki and this project, which was a couple of years ago, the vision they had for this robot, because it has this haptic capability, was things like it might be able to change like a catheter or take someone's blood, or at least dispense medication or brush someone's hair or cover them with a blanket. And in reality, that didn't come to fruition yet. But I sort of, this made me laugh, that providing highly speculative information on care robots could even be called misinformation. Scientists and research teams would send press releases of their robot experimentations and intentionally or unintentionally create high expectations of care robots. Prototypes may never end up in consumer use. And I think the imaginary of what we think robots can and should be able to do is like so shaped by speculative fiction and science fiction that we imagine like highly humanoid robots that can do all sorts of human-based tasks, when the reality is more like what you saw in that video, and actually not even that such came to pass. And even on Touch Lab's website, again, they have this image of the kind of trope of a robot designed for space is coming to Earth to work in a hospital. And they actually have this image, which also really made me laugh, because it's this very much like tech bro, Elon Musk futurist fantasy, where like you wouldn't get the Wi-Fi or the bandwidth to operate this robot on Mars, much less get it there. So yeah, there's a lot of like speculative imaginaries, like really interwoven into what the roboticists think robots could and should be able to do. And so that was, but one of the things that has come since the COVID pandemic is certainly a kind of sense that robots might be able to help in terms of infection control. And as I'll say at the end, this is actually probably the only use that all the nurse clinicians who are actually trained to use the robot could imagine that like this robot might be useful for, is that you could, if you had like a COVID ward or an Ebola ward, instead of sending a human clinician in to do basic care tasks, you could send the teleoperated robot in, or have a robot in the room already, so it doesn't have to breach a kind of infection barrier, and it could do kind of more complex clinical tasks than you would be able to. So the idea of robotics kind of got a surge in COVID, where there was this lots of kind of press, and this is just one random headline I found, and a lot of research articles that said that like robots could be dispensing medication, dispensing food, cleaning robots could be going around hospitals, disinfecting. So there was a kind of surge in interest, and I think funding as well, to explore the idea of how healthcare robots might be operationalized. And that was one of the headlines about the Touch Lab project, which is like, this could help reduce the spread of hospital infections. And that was one of the kind of selling points for how they got funding. So I really like this paper by Benjamin Lipp called Robot Drama, Investigating Frictions Between Vision and Demonstration in Care Robotics. And Benjamin Lipp is an STS scholar who's done quite a bit of field work looking at how robot trials are carried out, particularly in care homes for older adults, so companion robots or robots that might help with basic kind of home tasks or care tasks. And he kind of comes up with this idea of robot drama, which is exploring the frictions between vision and demonstration. So what roboticists think the robots should be able to do and what actually can happen in practice. And he talks about how roboticists adapt and strategically simplify test situations in order to support the robot's operation. And I've seen him present on this before, where he'll show like, there isn't a good example in this room, but like say a messy kitchen counter with all the appliances and the food and the knife over there and all that, the kind of mess of a real human kitchen. And then when they do the actual trial with the robot to get the robot to retrieve something, they'll take the carpet away because they know the robot can't go over carpet. They'll clean up all the mess, so there's just like one object on a blank surface, so the robot can identify and retrieve it. So there's a kind of theater, as he writes about, a staging of these test environments. So robot dramas are not simply about staging older people at home, but also about accommodating robots by controlling home environments. So there's a kind of artificiality that is created in order to make these robots succeed and be able to kind of achieve the task-based things that they are designed and programmed to do. So what was different, I guess, with this trial was that it was in a real hospital ward, and this is some of the pamphlets that were put in the ward to inform staff and patients and the public, like families that were visiting and stuff, that this trial would be going on, so they wouldn't be like terrified when they saw this thing coming down the hall. And obviously, anyone who interacted with the robot had to consent to that and be willing to be part of the trial. So not all patients were interested. And of course, it was a stroke ward, so it was mostly older adults who probably would be a little bit skeptical. And then, yeah, we went to the hospital and did some field work. One of Sarah Nettleton went back and did a few weeks of ethnography as well. And we all had to go like operating the robot and stuff. So there's Nick Brown and Carl Atkin there, the robot going around. So I guess the key thing to emphasize, because this was like a real point of confusion for patients, the robot is not autonomous. So anytime you see it moving around, it's because there's a human operator sitting in a chair moving it around. So it's always this kind of intertwining or entangling of human and machine for it to be operational on the ward. Okay, so this is just some background about how I got involved in this project. It's a long time ago. I wrote a bit about telepresence and embodiment, and considering how we might create a remote body through like transposing of things like not only vision and auditory senses, but also motor action in a remote environment through a technological medium. So I did specifically consider the case of technological re-embodiment through robot bodies. And I'm going to talk a bit now about telepresence and then the kind of thesis of the paper that we wrote together, so I've given quite a bit of background now. Okay, so telepresence, we've all heard this from before, is the experience of presence in a temporally or spatially distant real environment by means of a communication medium. So it's kind of just a fancy way to say like a Zoom call. So you've got your senses transposed into a remote environment. So things like live TV coverage or webcam or video conferencing are basic examples of like simple observational telepresence where you can kind of see and hear something in a remote environment where your physical body is not located. And there's there's different ways to schematize types of telepresence. This clicker is very, sticky. So we can have observational telepresence where you don't interact with the remote environment, you just observe it. Simple telepresence might be something like remote control, where you're operating a drone that has a camera and you can see through the drone, but you're also moving it around the environment. Enriched telepresence, which is kind of what I'll focus on today. And then the kind of dream is high fidelity telepresence, which has anyone seen The Peripheral, that Amazon show about William Gibson's novel, which is kind of what's imagined there, one person, like where you've got like an avatar that looks just like you and senses and feels and talks and everything just like you, but you're kind of transposed into it through some sort of technological medium. So close to or as good as in real life, I guess is the idea. So enriched telepresence is things where you might, it's not just seeing and hearing in the remote environment, but also you might transpose like motor action or other forms of agency, communication, more vitality and expressivity through than you can through just an observational or simple telepresence. So telepresence robots are already existing in healthcare, and there are quite a lot of examples. And the basic example is something more like this, which is where you have a kind of essentially like a roaming iPad, like an iPad on a thing that can move around. And so these kinds of telepresence robots, as it says here, enables remote patient-doctor relationships. So if you have a clinic in a remote environment where you need to like get the opinion of a specialist who doesn't live near that hospital, you can use these kinds of robots. The thing is obviously that there's no physical interaction, so that the robot can't touch a patient or take bloods. There have been versions of this kind of robot designed that have things like blood pressure cuffs that the patient themselves or a nurse who's alongside the patient could then use to do basic observations, so like stethoscope or blood pressure observations. That kind of telepresence is quite simple when you consider the very sophisticated telepresence that happens in medicine through telesurgery, where surgical operations are performed by a surgeon using a surgical system that provides limited but multi-sensory feedback, so usually auditory, visual, sometimes haptic, like pressure feedback to a surgeon, so that they can perform an operation. So that it could be that the surgeon's like in one room of the hospital doing keyhole surgery, very microscopic, but it's amplified for them on a screen so they can do things that would not be possible in the real field. So unlike the simple telepresence of a roaming iPad, this form of telepresence involves transporting one's motor movement, and not only that, one's skilled motor movements as a clinician into a remote environment. And telesurgery is quite advanced and sophisticated at this stage. The first transatlantic operation was on the 7th of September 2001. It was called the Lindenberg operation, and it was performed by surgeon Jacques Maresco in New York. He was operating on a patient in France, and it was a minimally invasive gallbladder removal. And the surgery was named after Charles Lindenberg, the first person to fly solo across the Atlantic. So what I guess is different about this kind of telepresence in a clinical and healthcare environment is that this is not social. So obviously the patient is sedated, is not interacting with the surgeon. And what's different is that Välkky is a social robot. So there's species of robot called social robots, which actually interact and have intersubjective and intercorporeal relations with humans. So he's a social robot, he's a social telepresent robot. So not only does Välkky transpose a clinician's motor movements into a remote environment, it also attempts to transpose the clinician's sociality. So their capacity for expression, expressivity, and communication and care. And then like the press releases that were, and all the press that was around Välkky, you might have noticed it's under the photos, it says stuff like, and we imagine Välkky will be able to brush a patient's hair and cover them with a blanket. So it's not just clinical tasks like taking blood or changing a catheter, not just like really like clinical task-based things that they expect Välkky to be able to do, but also social caring roles that you would expect from a flesh and blood nurse or care worker. So Välkky is a social care robot, and Välkky communicates with humans, engaging both intersubjectively and intercorporeally. And I guess, again, it's important to remember that Välkky isn't an autonomous robot. There's always a human behind Välkky, operated behind or in or standing in for. So Välkky is standing in for substituting the nurse's communication and intersubjectivity and intercorporeality. So once we collected the data, and I should say we designed a kind of set of interviews for focus groups, nurse clinicians who are being trained to use Välkky, hospital managers, nurse managers who were like in charge of deciding this trial was going to happen. And then we also we're going to interview 6 patients, but in the end we only interviewed 1 patient because for lots of reasons, some were discharged, some decided they didn't want to anymore. So we just had 1 patient interview, unfortunately. But I helped design the questionnaire, and we did focus on like experiential. I was trying to get to the more phenomenological side of what was going on. And after looking at the data, this idea of striving for presence kind of came to the fore, where nurses operated Välkky in order to engage with patients on the ward. And to facilitate these experiences, we found that clinicians were striving for presence in their use of Välkky. And this idea of striving for presence, which is a term we kind of came up with, is connotes the attempt to close the gap between the remote environment and one's immediate field of perception and action, to create the perceptual illusion of non-mediation, as Lombard says there. So what we're trying to do is, when you're using the technology, it's not like I'm using the technology in order to see the world, but I'm in the world. Rather, the technology becomes this kind of transparent medium that enables direct engagement with the remote space. So that was the idea of striving for presence, in different ways, the clinicians striving to be present in the remote environment. So again, really love the idea of the robot drama, because it really was drama, the whole thing. So there was like the drama of the hospital infrastructure, which was that like before the trial happened, and this is a really old hospital with like not great Wi-Fi, but before the trial happened, the roboticists were reassured that the Wi-Fi, the broadband levels would be augmented in the ward where they were, such that this could actually be operational, because there's so much data being transmitted from Välkky anytime anyone's operating it. Välkky's got like a 360 camera at the top of their head. So if you're operating Välkky and you turn your head, you can just see what you would naturally see behind you as a human, or if you look down or around. So that, like, and to have that at quite high fidelity is like, takes up quite a bit of broadband instead, and also operating Välkky and the haptic feedback and all of it. But in reality, that didn't happen. So there was a lot of issues with the broadband, which meant that the operational capacity of Välkky was much less than was expected, and the haptic side of it, which is really the USP of the whole thing, which is like, it's a robot that can touch and be touched, and this makes it safe. That was almost not trialed at all. And then of course, Välkky was actually in the wild in a fully operational hospital ward, rather than in a kind of staged or kind of powered back environment. And then there were the choreographies of various bodies. So the whole time the nurses were trying Välkky, the roboticists were there as well. And every day the nurses would give feedback about what worked and what didn't work. And Välkky had like a kind of digital twin back in Edinburgh where they're based, and they would like tweak the digital twin, upload it back into Välkky, and then each day there would be like adjustments and changes. So there was this kind of tinkering going on, to use that idea from STS scholarship. That was for the 2 months the trial was running, that was going on every day. So there was quite a lot of drama in many senses. So what I'm now going to present the kind of core ideas is this like STS meets phenomenology. STS scholars meet me. So I'm going to talk about 4 modalities of embodied presence that we identified in the qualitative data, and I'll go through the 4 in turn, which is like the 4 different ways I kind of conceptualize the nurse clinicians were striving for presence. So first, I'm going to talk about presence that was enabled by technological transparency, presence enabled by skill acquisition, presence felt through affective, intercorporeal, and social resonance, and then presence enabled through recognition. So I'll start with the first one. So as I already mentioned, like if you're using some sort of telepresence technology, you can start to feel present, and not like you're just engaging with the technology, if the technology recedes. And like really simple example from Don Ivey, which is the idea of using glasses. The technology must not get in the way. So his example, the quote from him is, "My glasses become part of the way I ordinarily experience my surroundings. They withdraw and are barely noticed, if at all." So the kind of eyeglasses world formulation becomes like the eye and the glasses are one thing, and we're just interacting with the world. I don't even notice the glasses anymore. The mundane technology becomes intrinsic to our relation to our environment, to quote Michael, incorporating and expanding affordances. So you don't even know the technology is there anymore because it's just become part of you or your body's, to use a phenomenological term. So this is much more complex, thinking about the sort of technological transparency that would be needed in operating Välkky. So the nurse clinicians were sitting in a scorpion chair, which is like a chair that's used for gaming. I wasn't familiar with this before, but apparently it just gives you the sense, the position is such that your body becomes the most transparent it can be, because it's like kind of an effortless position, you don't feel the strain. So the idea is like the body recedes from awareness even more. There's a VR headset, a 360-degree camera input, joysticks to move the robot, and then eventually they were using the haptic level to get the feedback just from one hand. So feelings of being there in the room with patients were reported as fleeting or unattainable by the nurses. And there are frequent reports of the technology or one's own bodily sensations getting in the way. And what's, I didn't know this before because I've never really used VR, but apparently things like nausea, dizziness, headaches are very common if you're using VR headsets, and it takes some time to get used to it, and some people never do. Because of things like lag in movement, or blurry vision, that can kind of mess with your sensory systems and give you these symptoms. And then because of the problem with the broadband that was going on in the ward, there was lag in movement and action of blurry cameras. There was distracting audio feedback as well. So instead of seamlessly seeing through or experiencing through the technology, participants reported being consciously reminded of the presence of the technology and also the presence of their own bodies, which led to diminished rather than enhanced sensory capacity or capability. So the idea was like Välkky's got this like haptic feedback that's going to enhance what nurse clinicians can do. And also the other thing I should have said already, which is like Välkky also had an infrared camera. So as the person operating Välkky, you could look at someone and see if they had a fever, for example. So it was like extra human sensory ability. So there's a quote from one of our nurse operators. The camera was really a blurry vision that really makes me a bit less confident with movement. I think if there is rapid movement and people are moving around quickly, it can be difficult to spot or register the movement because people are jumping around a bit. The technology was also rendered salient and distracting as a result of audio feedback. One participant reported, every time I wear the headset, I can hear engines running in the robot's head. And also the direction of sounds are difficult to discern. So this is one of the things about the robot drama. When you put the robot in the wild, like on a busy ward, so if you imagine like the bustle of a hospital ward, there's doors closing, people talking, things falling on the ground, you know, beds being moved around, wheelchairs. There's a lot going on. There's quite a lot of noise and background noise. TVs might be on, radios might be on. And that was kind of more than the robot could kind of handle. All that audio sensory input was really confusing. And also it's really hard to tell where sounds were coming from. So if something fell on the floor, you didn't really know which direction, when you were in the robot, you didn't really know which direction it was coming from. So there was something about the mismatch between how our sensory inputs would acknowledge sound and sight and everything, and what the robot's sensory technologies did. So in short, there was not technological transparency. Not yet. So the second mode of striving for presence was this presence being enabled by skill acquisition. So I guess it's worth saying that Välkky enables tele-action, not just tele-presence. So nurses can move freely around the ward in Välkky, exhibit agency, interact with people and with objects. And there was a process of skill acquisition was enabled through training the nurses to operate the robot on the ward. And the nurses were first trained in a virtual reality system. So they didn't actually, they used a virtual reality setup for like a few weeks before they actually started moving the robot around. And I think that gave them a sort of different idea of what the robot was going to be able to do in practice. So you're probably familiar with Dreyfus's idea of skill acquisition, where we can master a tool or technique. So Dreyfus gives the example of driving a car, where eventually skills are incorporated into one's body schema. So we move from novice to proficiency through a kind of process of self-conscious reflection about how we might do something, to the point that we can do it unself-consciously, pre-reflectively, so we get a kind of flow in action. So when I drive a car, I can think about it, just drive, and then I can also transpose that into other cars. So once I've learned a skill on like one thing, I can usually very easily transpose it into another thing. And Merleau-Ponty gives that car example as well. If I possess the habit of driving a car, then I enter into a lane and see that I can pass without comparing the width of the lane to that of the fender, just as I go through a door without comparing the width of the door to that of my body. And the idea being that the skill acquisition can also involve this process of technological incorporation into the body schema. So it's kind of like I become one with the car. I know how wide it is. I know, when I'm parallel parking, I know where it ends, where it starts, just the way I know where my body ends and starts. And so the idea being that once the nurses got this, got closer to proficient skill with operating Välkky, that they would have that same kind of confidence moving Välkky around the ward, because Välkky's body was obviously quite a different shape and size than a human body. So skill acquisition, so moving from beginner to proficient, maybe not proficient, but was evident in the data, but certainly there was some sort of progression in skill, the nurses reported. So this is a quote from nurse operator 1. I'm feeling more confident now because we've had many trainings. I'm doing it more spontaneously rather than thinking about what I should do. Whereas before I was a bit nervous about bumping into walls and things, but now everything is a bit more confident. So you can see the kind of move away from being very self-conscious and deliberate to having more pre-reflective engagement. However, none of the participants reported experiences of flow or absorbed pre-reflective interaction, and perhaps that was a question of not enough training time. Also, the technology was actually very complex. There was a lot to take in at once, and I should say, like, the nurse participants, like the ones who had experience gaming, were better at doing this. And then there was one guy who was like a trained pilot, and I don't know why he was also a nurse, but he was really good at it because he already was, apparently when you're a pilot, you have to be able to keep track of like 15 or 20 things at once. So he was quite able, he looked like quite confident. And then of course the limitations in the infrastructure were huge factors in this. So but there were sort of two layers of skill acquisition involved. So first was like incorporating the physically proximate technology. So like the chair, the headset, the haptic glove, the joystick and all of that. So learning, like moving Välkky backwards and forwards. We're even getting used to, like, when you're wearing the headset and you look down, your legs aren't there, the floor is there, you know, stuff like that. Getting used to all that stuff when you're in that system. But then of course you also had to master Välkky in the world. And master the, you know, get used to Välkky, you know, when I move through the door, is Välkky going to fit? And all of that. There's like, yeah, this kind of nested relationship, which kind of following Ivy's schema about eyeglasses world was something like this, where you've got your body with all that stuff with Välkky, and then that's going to interact with the world. And so this would be the idea of re-embodiment. You're re-embodying yourself into the remote environment through the technology, which is the robot. However, re-embodiment remains elusive. And this is nurse operator 3. It is not easy recognizing the dimension of the robot, especially if you're really close to something. Sometimes when I go through a narrow doorway, it's not so natural, like I feel like I'm going to hit the walls. You can see that idea that Merleau-Ponty identified not being actualized here. All right, and then moving into the kind of more human side of this, thinking about presence felt through affective, intercorporeal, and social resonance. So I think there's lots of literature in STS that identifies that when technologies are designed for healthcare, they are often designed with task-based goals in mind, rather than having like care or inclusivity or affective relations as the goal. So it's like, yeah, if the robot can change a catheter and take someone's temperature, success. But that might not capture what actual care is, which involves intercorporeality, affective responsiveness, and so on. So the kind of concept from Merleau-Ponty of intercorporeality is useful because we're not just talking about task-based, operationalized things happening between a robot and a person. We're talking about two bodies interacting, a robot body and a human body, and the kind of kind of conversations that subtend intersubjectivity. So through interbodily resonance, nurses and patients can tune into each other's bodies to varying degrees, allowing communications, meaning making, and sort of different types of ethical affordances. So what might feel ethical or natural or caring in a human-to-human interaction might not in a different sort of interaction through a robot and others. Right, not too far, go back. Yes, okay. So all nurse participants reported that when they were in Välkky, it was harder to pick up embodied cues and to respond spontaneously and appropriately. So nurse operator 2 said, to be honest, it's quite difficult to keep up the conversation through the robot with the patients because I can't see their expressions and their non-verbal hints. So the kind of intercorporeal layer of communication, which would be non-verbal or pre-reflective, the kind of choreographies we have been socialized to do as bodies in our particular social milieu, is kind of lost when you're in Välkky or using Välkky. As a human, I want to hear the patient better, I would lean over, but as a robot, I can't. So the usual bodily cues are disrupted. And all nurses reported feeling emotionally distant from patients, unable to communicate effectively, and not being able to provide the human touch, both literally and metaphorically, that they saw central to nursing care. And then I just threw this Dreyfus quote in from 2000, where he says, even the most gentle person-robot interaction would never be a caress. One could not use a delicately controlled and touch-sensitive robot arm to give one's kid a hug. Whatever hugs do for people, I'm sure telehugs won't do it. And to date, I think, based on the technology, that Dreyfus is probably right about that at the moment, based on what Välkky was able to do. Okay, so the last one I'll talk about, and then I'm going to wrap up, is presence enabled through recognition. So as I've said several times, Välkky is not autonomous. There's always a human operator behind Välkky. But the cost of that is, of course, that nurses' bodies were absent from the ward. They weren't there. They were there as Välkky, and most people and patients initially didn't realize there was someone in and controlling the robot. Like, basically, everyone just thought, because Välkky's got a name, it's quite expressive and cute. Everyone just thought it was Välkky was Välkky. There wasn't this kind of consciousness that there's like a human operator behind Välkky. And sometimes they would, because the nurse could talk and their own voice would come through, so then patients would be like, oh, it's so-and-so nurse or whatever, you know, they could understand that, but it would almost always have to be explained that there was someone operating. So everyone just took Välkky at face value, and Välkky was its own kind of character. People talk, you know, the nurses made like clothes for Välkky. Välkky was like a personality that everyone interacted with independently of the nurse clinicians that were operating it. So this led to a little bit of reflection from the nurses, and I wish we could have delved more deeply into this aspect of it, about lack of recognition as nurses' identities, appearance, and uniform were effaced. And they often said that they're not interacting with me, they're interacting with the robot. So there was always this like distinction between the clinician operating the robot and the robot. So as you know, in political theory and also in phenomenology, being recognized is a crucial experience which underpins social interaction. Recognition, as Axel Honneth kind of less theorized this, I suppose, is the making visible of a person with the aid of suitable actions, gestures, or facial expressions to the fact that the person is noticed affirmatively in the manner appropriate to the relationship in question. So that's quite abstract, but actually had very like concrete ramifications in this setting, because no matter which nurse was operating Välkky, their physical identity was homogenized behind Välkky's robot morphology. So Välkky was like a shiny white, kind of humanoid robot. So unlike avatar identities in video games, for instance, where users' appearance, expressivity, and vitality can express their identity, a telepresence robot avatar has a fixed morphology. So basically it just looks the same no matter who's operating it. So things like age, gender, race, ethnicity, disability are all effaced. And then this has questions for like diversity, inclusion, obviously. And Mark Patterson has been writing a bit about this. He's a sociologist in Pittsburgh. He writes, robots do not look like people, interact with people in ways that reflect even the basic aspects of society's diversity. And Tom Sparrow, I'll show you the paper in a moment, asks this question, is there a race problem in robotics? Because basically most robots are white. It sounds kind of funny, but it is a question. And then recent research, like really recent research about cultural diversity in Finnish healthcare systems argues that encouraging cultural diversity among healthcare workers has an overall positive effect to address health inequality, build trust, minimize workplace conflict, retain nurses, and address nursing shortages. So there is quite a lot of literature that says like if you're a minority ethnic individual in a healthcare system, you have better health outcomes if some of the clinicians that are treating you or supporting you look like you or can relate to you. So cultural diversity is just like, you know, it actually has concrete effects in lots of different ways. And there is this kind of emerging literature. I mentioned that paper, Robotics Has a Race Problem, and this is a really interesting book. It's called Surrogate Humanity, Race, Robots, and the something of technological, and the problem of technological futures, very blurry. And Mark Patterson has written an article recently about racial and gender bias in AI and robotics. Why are so many robots white? So there are like really important questions to be asked about like it's not just like about task-based clinical care, but like what are the broader social political consequences of implementing technologies like these? And they're designed by certain types of people for certain types of people, and the kind of imperatives behind the design is usually task-based rather than inclusivity-based. So there's a kind of mismatch sometimes between reality and the kind of utopian techno-futurist visions of these kinds of tech designers. Yes, okay, conclusions. I think this is almost my last slide. So is there any potential for Välkky and provisions of post-human care? So there is a kind of like really optimistic post-humanist literature about technology and like more than human technology and its potential for healthcare and care contexts. And I guess one thing to point out is like care and technology are inextricably intertwined, and innovations like Välkky aren't like a radical break from care as we know it, but instead further extend our understanding of human and clinical care opportunities. So we already use a whole range of technologies in clinical care contexts. So it's not something completely out of nowhere, but and then Amelia Välkky, who's written lots about post-human care, is very optimistic about these kind of more than human opportunities. And she writes, post-human care is not about replacing human care, it's about augmenting and hybridizing it. Or more precisely, it's about exposing the hybridity, the cross-species, organic, inorganic networks already at play and ripe for exposure, expansion, and augmentation. However, in contrast to theoretical optimism within post-human tech studies, in the wild, nurse operators found it difficult to see how the robot could do anything of use. They did not see Välkky as having the potential to substitute humans, like that was really clear right from the beginning. And kind of the only practical application they could see for something like this was infection control. And then really the only cost-effective and practical way forward for a robot like Välkky is to become autonomous. So it's not human operated, because like, why would you take a nurse clinician off the ward to put it in a robot that can do like hardly anything that a nurse can do? It doesn't make sense. So it could be that it's controlled by AI rather than human operator. And then Zaki, the lead roboticist, was chatting to us when we were on the very busy and hectic hospital ward, and he said, oh, we wouldn't have these problems in space, implying that the messiness of real life got in the way of their imaginaries of what robots should and can or would be able to do are based on that kind of Välkky's on Mars kind of thing, rather than. So it was really interesting because they were putting it in a real operational ward and trying to get it to work. But yeah, it was very interesting. And I should say, like, they're still trying to get funding to do a follow-on trial, so to put Välkky back in LATSO and do more field work around not only what like Välkky can do clinically, but also the kind of human and experiential side of it as well. All right, that's it. Thank you.